Hi, everybody. Thanks for joining in. So my name's Asaff Harel. I lead the MS clinics in Northwell. I'm a neuroimmunologist. We're going to be talking about neuroimmunology, of course. So first things first, what is neuroimmunology? What do we mean by that? What does this talk about? Because that's sort of a broad, broad term. So broadly, neuroimmunology refers to the study of how the immune system interacts with the nervous system. There are PhDs, there are researchers that are considered neuroimmunologists, but for the purposes of this talk, and we're going to be talking about clinical practice, a neuroimmunologist is a neurologist who specializes in such immune disorders that can affect the nervous system. And some of them are listed there. So MS, multiple sclerosis, is by far sort of the most common neuroimmunological conditions that we deal with. And then there are some other less common conditions that can be related, but are certainly different beasts, such as NMO, or Neuromyelitis Optica, Autoimmune Encephalitis, and then a whole list of others that sort of goes beyond the scope of this talk. What I really want to emphasize going through this talk is that, and what I tell patients who I treat with neuroimmunological conditions such as MS, NMO, is that this is not the same world that existed 20 years ago or even 10 years ago. And there have been really dramatic advancements, even just over the last 5 to 10 years, in the treatment of these conditions, whether it be therapeutics, diagnostics, and we'll go through a little bit of that. Since we have different, we have people at different levels in their career, just a question about sort of how does one become a neuroimmunologist? And really, as I mentioned, so we're neurologists, so it's 4 years of medical school at least, right? And then 4 years of residency, so that's a 1 year internal medicine preliminary year. So it's the internship followed by 3 years of neurology training. And then on top of that, most neurologists end up subspecializing these days. The sort of the era of the general neurologist is sort of waning as it is with a lot of different specialties. We're becoming more and more subspecialized, and then so people do subspecialty in neuroimmunology and MS. So that's depends on the place. Usually 2 years of fellowship, sometimes only 1. Okay, so to start off with, so as I mentioned, multiple sclerosis is the sort of the most common one out there as far as neuroimmunological conditions, and it's in popular culture, right? Everybody's heard about it. I don't know if everybody knows what it is, but everybody's heard about it, and these are some sort of famous, recognizable faces of people who have come out about their diagnosis of MS. You have so Jack Osborne is on the top left. Montel Williams, Ann Romney has been very active in advocating for people with MS. She herself has it, of course. Neil Cavuto, Selma Blair has been in the news, over the last year or two regarding her diagnosis. The one on the middle right there is Art Alexis. He's the lead singer of Everclear band. I don't know if people have heard of that. The bottom left is the woman from The Sopranos, the actress from The Sopranos, Jamie Lynn Singer. There's Richard Pryor, and the Osmond brothers all have MS. And so as I mentioned, it is in the popular consciousness. So what is MS? I like to break it down into simple terms. So MS literally sort of means, you can think of it as meaning multiple scars, multiple plaques. And so we like our old languages, so we don't just say that. We like to be confusing. Just to break it down even further, so MS is an autoimmune demyelinating condition that affects the central nervous system. So, as I'm explaining it to patients, I really like to break down the three, those three terms. So autoimmune, of course, you probably all know that means that the immune system is very effective at fighting off bacteria, viruses, you name it, functions fairly normally from that standpoint, but it can, for whatever reason, become overactive or target the wrong thing, and so it ends up targeting oneself. And in the case of MS, it's what's called a demyelinating condition. So myelin, as you know, is the coating surrounding nerve cells. It allows for proper conduction along axons. And so in the case of MS, there's an immune attack against myelin. And of course, it affects the central nervous system. So there's myelin in the periphery, but in the case of MS, it affects the brain and the spinal cord. MS is a chronic condition, so so it's not a monophasic, it's not a one-time thing, but it can affect somebody throughout decades, and we'll talk about that. Today, we'll be talking about MS and some other conditions. I'll start off talking about the cause of MS, who gets MS, so demographics, some of the symptoms. We'll talk a little bit about the subtypes, how we diagnose MS, and then a little bit about treatment and future directions. So the truth is that we don't know exactly what causes MS. We know that there is a genetic predisposition, as with a lot of different conditions. It's not a one-to-one hereditary relationship, such as with autosomal dominant conditions, et cetera, but there is a predisposition. So if you think about it, if somebody has a first-degree relative affected with MS, their chance of having MS is about 2 to 5%. So just to give you a comparison, in the general population, the risk is probably somewhere around 0.2% or so. And so we're talking about a substantially higher, 30, 40 times higher risk of developing MS if somebody has a first-degree relative that has the disease. We know that there's a genetic predisposition. We know that risk increases with monozygotic twins. So if somebody has a monozygotic twin with MS, the risk is about 20%, 1 in 5 that person will also have MS. There's an association with the most sort of well-known association, risk allele associated with MS is HLA DRB1 1501. But there are a variety of different genes. There are close to 200 genes that have been identified that are considered to be risk genes for MS. Most of those are involving the immune system in some way. Some of them we're sort of not sure what they do. On the flip side of things, we talked about nature. There's also nurture, right? On the environmental side of things. So, that is something that is very, very difficult to study. And people have looked at immunological, microbial, vascular, factors, and then environmental factors as well. And we know that altogether, this leads to autoimmunity and demyelination. So as I mentioned, there are a lot of different genes out there, genetic factors that are associated, so alleles that are associated with risk for MS. And this is just a busy slide to show you how complicated it can be. The environmental factors, as I said, it's very, very difficult to study. It's very difficult to, as with all sort of observational research, right? You're looking at patterns, trends, correlations, but it's very, very difficult to prove causation. And so just to go through the list, so we do think that as with all autoimmune conditions, pretty much, there's the hypothesis of molecular mimicry, the idea that the immune system is targeting something out there, and that something looks like myelin, or proteins within myelin, and so the immune system attacks that other entity, that other foreign object, and then believes that its own self is also foreign. There hasn't been, in the case of MS though, there hasn't been a target. So we don't have, we've never found with MS an antibody to something within myelin. So it's a little unclear. We do know that vitamin D is important. So it seems to be that low vitamin D increases the risk for MS. It also increases the risk for worse MS, so worse number of relapses. And we know that vitamin D has important functions in immune regulation. And so we do recommend supplementation with vitamin D for those people who are deficient in it, who have MS. Part of the vitamin D question is it the vitamin D or is it something else? So as I mentioned, there's an association between low vitamin D and worse MS, but is it the low vitamin D itself, right? Is there something else going on? So there is some research to suggest that sun exposure, so low sun exposure during certain parts of life, can be associated with an increased risk of MS. So, but again, we get into that. It's an association. It could be a marker for something. People who maybe don't feel as well, maybe they don't go out as much. So it's very complicated to study. There are associations that we see, but nothing that we can prove is causative. On the microbial side of things, there have been a number of different viruses that have been suggested to be associated with risk for MS. The big one is EBV, Epstein-Barr, which causes mononucleosis. So what they've shown is that, so in the general population, about 90% of us, when we reach adulthood, have antibodies to EBV. So it's pervasive in our environment. When it comes to MS, pretty much everybody has those antibodies. So there's an association, but is it a one-to-one causation? Absolutely not. And could it be causative? Could it change the immune system in such a way that it promotes the development of MS? Possibly. Or is the immune system already different? And maybe that impacts the response to this virus. We don't know. The gut microbiome is a very big area of research these days. So people are looking at microbial. So the gut microbiome refers to the normal commensal bacteria that are in the gut, and composition of that bacterial population may impact we know that it impacts our immune system, but may impact our risk for certain immunological conditions. And people are looking at it in all sorts of systemic autoimmune conditions, rheumatoid arthritis, IBD, you name it, but also with MS. Right now, we don't have a clear-cut, again, 100% understanding of this. This is a very, very complicated subject. And again, is it the immune system leading to an altered gut microbiome that we see in people with MS, or is it the altered gut microbiome that is promoting the development of MS? Again, we just don't know. There have been people looking at potential vascular causes of MS, and that's been largely disproven. That's CCSVI. People would get venous surgery, which didn't end up actually helping anybody. And then the number of different toxic toxins out there, environmental causes that have been disproven. So back in the day, people thought that dogs were carrying a virus that was causing MS. Told people to get rid of their dogs. There was no actual proof there, and that's since been disproven. Aspartame was a big one back in the day, but there's no association there. There is some data on air pollutants. being associated again with increased risk for MS, but who knows? Because again, I mean, could that have something to do with sun exposure? It's very complicated. We don't know 100%. Distance from the equator is interesting. So getting back to sun exposure and vitamin D. So it seems to be that the farther you get from the equator, the higher the incidence of MS. And so that goes along with the, so people farther from the equator might have less sun exposure, they have lower vitamin D, they have increased risk for MS. But again, there could be other variables here. The interesting thing about this is that if somebody emigrates from a low risk environment to a high risk environment, meaning farther away from the equator, before puberty, they inherit the risk of the high risk environment, of the new environment. If they emigrate from a low risk environment to a high risk environment after puberty, they still retain that low risk. And so there's some suggestion that maybe something is important, something during those adolescent years impacts risk. So the prevalence of MS. So the data here is a little bit old, as far as 2.5 million people affected worldwide. Don't really have accurate data for the world that's sort of more up to date. In the US, just over the last few years, there's been an evaluation by the National MS Society, and we think that close to 1 million people are affected, live with MS in the US these days. As with a lot of autoimmune conditions, women outnumber men 4 to 1. And the average disease onset is a condition of the young, right? So it's average age of onset is 30, plus minus 15 on either end. But it can happen, there's pediatric MS, there's and then certainly people can be diagnosed at older age as well. Most people get diagnosed with relapsing MS. We'll talk about what that means. That's characterized by sort of relapses, so acute exacerbations, sudden abrupt symptoms, and then remissions or improvement in symptoms. And then before the era of treatment, about 50% developed what's called progressive MS within 10 years, which was characterized by a gradual level of decline, rate of decline over years, without these sort of acute bouts of worsening symptoms. And we think that in the modern era, we're diagnosing differently, we're treating for sure. And so the most recent data does suggest that that we're doing something about it, that it's improving, and it's probably we're thinking that we're reducing that sort of second stage of MS, that progressive worsening, gradual worsening over time, and it's probably only affects about 5 to 10% of people in the modern era. So just to talk a little bit about the impact of the natural course of MS. The field has moved so quickly over the last decade that we really don't know where we are right this moment, but it has been one of the leading causes of disability among young adults. It's a chronic disease, and it starts at a very early age compared to other neurological conditions, and it spans decades. So this is when we talk about Alzheimer's and Parkinson's, those are diseases that tend to affect people at much older ages. This is one of the most common neurological conditions to affect young adults. It's been estimated that about 30% of people have had severe disability. Again, we don't have updated numbers in the last few years, and 70% unemployment rate. Those numbers are probably a little bit better these days, but it can certainly still affect quality of life to a large degree. There's also an economic burden that we never really talked that much about of having MS. So total annual cost for somebody with MS outside of, so I mean, this is purely, lost wages, healthcare costs, et cetera, $69,000, and the cost of in the U.S. These are a few years old, so it's probably higher than that, but 28 billion per year. So quite a condition that affects the entire country quite a bit. So talk about immunopathogenesis of MS, which as I alluded to is complicated, sort of to some degree outside the scope of this talk with regards to the details, but there's no one specific antibody when it comes to MS that attacks the nervous system. We know that at some point in the periphery, so in the peripheral part of the body, in the periphery, outside of the nervous system, the immune system gets primed. And we don't know exactly why that happens, but we know it happens outside of the central nervous system. And so what ends up happening is that there are autoreactive immune cells, primarily lymphocytes, so B and T cells, that get primed in the periphery against an antigen, and then that leads to travel across the blood-brain barrier to the CNS, where again, it's as you can tell, this is a busy slide. It's a very, very complicated, complicated situation. You have lymphocytes, you have monocytes there, some neutrophils as well. Anyway, causes release of cytokines and resultant attack on the myelin sheath, resulting in demyelination, which leads to disruption of neural signaling and the symptoms of MS. So normal, here's a picture of a schematic of a normal myelinated axon. So as you remember, myelin is important in efficient conduction in order to essentially get the signal over to the synaptic cleft, to the postsynaptic neuron. And if there's an acutely demyelinated axon, the signal just doesn't really go through. And so that leads to the acute symptoms. So if we're talking about relapsing MS, it's an acute attack. This is what happens. People have the symptoms, and then there can be repair over time. So either there's remyelination of that axon, and the axon stays intact, and people regain function. People can have a chronically demyelinated axon, but there's compensation, so conduction can be restored by an increase in sodium channels, or there can be a degenerated axon, which can lead to permanent symptoms. And that's when we talk about demyelinating disease, we have to remember that it's not only so the myelin might be the target, but the inflammatory milieu there is not healthy for the neurons themselves, and there can certainly be axonal degeneration. The hallmark of MS, as I mentioned, multiple plaques or multiple lesions, multiple scars, whatever you want to call it, and that's the hallmark of MS. So classically, it was thought to be a white matter condition. So you can see that it does affect. There are scars here in the white matter. MS likes to affect the corpus callosum, which is heavily myelinated. What we know now is that it's not only, while the white matter lesions are the hallmark of MS, there is some inflammation in other parts of the nervous system. So there are lesions of the cortex as well. There is some inflammation around the meninges as well. It's just something that we don't image that well. So you can see on the right side here, you can see that we're doing pretty, we can easily image the white matter lesions. Those are all the white fluffy things. I don't know if you can see my cursor, but we need a special sequence called double inversion recovery here to really highlight a cortical lesion. Okay, so to talk a little bit about the symptoms of MS. MS is a highly variable disease, and it really depends on the severity, the ability to compensate for injury. Location of injury is a really big one. So during a relapse, people can have a sudden loss of vision. So in one eye, that's what's called optic neuritis. So you can see that there's, again, I don't know if you can see my cursor, but there's inflammation. There's sort of brightness on the, so it's the left eye, it's the right side of the screen. It's reversed, but you can see that there, it looks a little bit brighter behind the globe. That's suggestive of optic neuritis, inflammation of the optic nerve, which is heavily myelinated. There can be sudden weakness. So this is an example of plaques lesions within the cervical spinal cord there. You see where the arrows are. Numbness as well, of course, depending on where you hit, what tracts in the spinal cord you hit. Double vision can be seen with brainstem involvement. So this is an example of a lesion of the MLF causing what's called INO, which is the inability to, when one eye moves out, the other eye, tries to move in but cannot. And that's a fairly common symptom with MS. People can have trouble walking, dizziness, or imbalance. Outside of the relapse, people can have other symptoms as well. So chronic symptoms, so fatigue and depression, very, very, very common in our population. There can be stiffness in affected limbs due to spasticity, decreased mobility, tremors. There can be transient, sort of temporary abnormal sensations, what we call paresthesias, urinary issues as well. Pain is a big one. You can see that the list is pretty long. Cognitive difficulties over time if we let this go. And the goal of MS, MS care, I'll be talking a little bit about medications, but the goal of MS care is not only to treat the MS, but to treat the symptoms that people may have due to neurological injury from MS. We have to remember that. As far as intermittent abnormal sensations go, just to give you an example of just a couple of interesting ones. So Lermite's phenomenon refers to when there's neck flexion forward, there can be sort of a shock-like sensation down the body. That is sort of the classical, but it can be sort of any symptom. I've had one person tell me it was sort of a little bit of a vibratory sensation in the feet whenever they put their head down. But it's associated with lesions of the cervical spine, cervical spinal cord, and that's an MS is a common, within MS is a common phenomenon. Uthoff's phenomenon refers to the idea that heat exacerbates the symptoms of MS. People sometimes get this a little wrong. They think that heat is bad for MS. It's not necessarily that way, but a proportion of individuals, if they are overheated, can have worsening symptoms temporarily. But then once they cool down, the symptoms go away. So it does not make MS worse. And it's thought, this phenomenon is thought to be due to less efficient conduction when the body is overheated within demyelinated areas. So I alluded to the subtypes of MS a bit, but MS can cause disability in two potentially overlapping ways. People can have relapses, sudden attacks. Typically that's accompanied by new lesions on the MRI, typically by improvement and remission, or people can have a gradual deterioration in level of function. So you can see on the left here that this is what we refer to as relapsing remitting. So people can have a worsening in worsening condition and then get better for a while and get better back to normal and then have another episode, what we call a relapse, right, or an exacerbation. People can have a stepwise accumulation of disability that way because they don't often, they don't always get back to normal. About half the time there's something left over from that neurological injury. Secondary progressive, we mean that after a time of relapses, there can be a gradual worsening in level of function. And primary progressive, we refer to if somebody has never had some relapses of MS before. So because of these sort of, the relapsing form and the degenerate and the progressive form, we sort of hypothesize that there's, certainly there's inflammation, but perhaps we don't really know the pathophysiology of why people start to get worse later on gradually. And again, not everybody, but is there a degenerative component? Is there an energy metabolism component? We don't know why that happens, but it sort of behaves like a neurodegenerative condition. For the diagnosis of MS, we require essentially characteristic lesions of the central nervous system, disseminated in time and space. So what does that mean? And before we get to what that means, I want to just, the other caveats is that there should be objective evidence of the disease on exam, and that we exclude all other causes, or that there's no better explanation for the symptoms that the patient has. So when we talk about better explanations, there are a whole number of MS mimics, B12 deficiency, which again doesn't usually cause the same pattern, but sometimes it can get confused. There's certain infectious etiologies that can sometimes get, confuse people and think that somebody has MS. Vascular issues, malignancies, genetic conditions like leukodystrophies, other inflammatory conditions that affect the body as a whole, or structural conditions like spinal cord compression that can cause abnormalities in the spinal cord. So how do we diagnose MS? So I mentioned dissemination in time and space, right? So this is the McDonald criteria for the diagnosis of MS, the most up-to-date criteria. So for dissemination in space, what that means is that there are that there's involvement in of multiple parts of the central nervous system. And specifically with MS, what we look for are what are called periventricular lesions. So I mentioned they like to affect there are little venules essentially that come out, around the ventricles. MS likes to affect those areas, leading to periventricular lesions. Juxtacortical lesions are lesions that really abut the cortex but affect the white matter, as you can see on the second from the left. Infratentorial lesions, so lesions that affect the brainstem. So you can see here that there's a lesion of the brachium pontis, and then lesions of the spinal cord. So with MS, there are distinct small lesions typically, and this is a picture over here of the cervical spinal cord, and you can see that there are probably 3 lesions within that spinal cord, looks bright on that image. Now, dissemination in time is the other criteria. So what we want to see is, what we're looking for is simultaneous contrast-enhancing lesions and non-enhancing lesions at any time. Actually, the asymptomatic part, actually with the most recent criteria was removed. So it's really just we're looking for contrast-enhancing lesions, non-enhancing lesions. Contrast-enhancing lesions are the lesions that when we give gadolinium into the IV, they light up with the gadolinium because there's a break in the blood-brain barrier and acute inflammation. So it tells us it's a new lesion. Non-contrast enhancing lesions are, we consider them older, at least a month or so old, and so we can obtain that information that this is a more chronic condition as opposed to a one-time thing, just by looking at the MRI. Or if we don't have that, we can follow the MRIs over time. If there are new lesions over time, we meet that criteria. Or people can await a second clinical attack. People nowadays do not do that really because we know that treating early is actually associated with better outcomes. So back in the day, before the era of MRIs, people would wait for a second clinical attack. We don't do that these days. Now, the most recent criteria actually also incorporated CSF abnormalities. So what are called oligoclonal bands, which are basically, if they're present, it's indicative of intrathecal antibody production. and it's present in the majority of many people with MS, of most people with MS, not in everybody. And so, you know, if we're sort of on the fence, sometimes that's helpful. So that can take the place of dissemination in time in the most recent criteria. A lot of different treatments for MS. There are over 15 preventative treatments. The first treatment was only 27 years ago. So before 27 years ago, we didn't have anything to treat MS. Prior to 2010, we only had a few injectables and one infusion medication. The rest we didn't have. None of the orals before 2010. And we've had advances in the treatment of progressive MS only within the last 3 years. So really, many of these medications came out just in the last few years. They have a variety of different mechanisms. So some of them, like Copaxone, shift the immune system from a Th1 profile to a Th2, more immunoregulatory profile. Some help in decreasing permeability of the blood-brain barrier. Copaxone, one thought is that it almost mimics myelin because it looks like myelin. Some medications work by sequestering lymphocytes into the lymph nodes so they don't get into the target tissues. Some work by preventing lymphocyte adhesions and migration into the CNS, so keeping them in the circulation as opposed to in the target tissues. And then some are cell depleters. And it really has, you know, these advances have really transformed MS into a condition that, by and large, is manageable. Certainly, we have ways to go in the treatment of progressive MS, for example. So, sort of outside the scope of this talk, but we've made dramatic advances over just over the last 10 years. I want to shift gears a little bit. I know, yeah, I've got a little bit more time, so I want to shift gears a little bit and talk about a couple of other sort of conditions. So I wanted to talk about a 40-year-old man with a diagnosis of multiple sclerosis, or at least he carried a diagnosis of multiple sclerosis based on one episode of optic neuritis, which is inflammation of the optic nerve, one episode of myelitis, which is a lesion, you know, inflammation in the spinal cord, and abnormal MRIs. And he was treated with natalizumab, which is a very, very, very effective MS medication. And then he came in now with bilateral arm and leg weakness, sensory changes, and gait disturbance. So here's his MRI. And as I mentioned before, MS likes to cause sort of what are called short segment lesions in the spinal cord. So, you know, distinct lesions of the spinal cord. And as you can see here in the cervical spine on the left, you can see a very, very long lesion spanning multiple segments of the spinal cord. It's not the typical MS lesion. In the center, you see a lesion that almost looks like the typical periventricular lesion of MS, but it's sort of subtle, really abutting the ependema. And then you see some you know, periependymal lesions of the brainstem of the pons as well. So this is actually Neuromyelitis Optica, and the reason why I mention this is because natalizumab, which I mentioned before, the drug that this patient was on, can actually worsen Neuromyelitis Optica, and so the distinction is important. It's the other name for Neuromyelitis Optica back in the day was Devick's disease. We now, you know, we don't like to use you know, names of people anymore, and so we call it NMO, or Neuromyelitis Optica. It has a very strong female predominance, so 6-to-1. It's more common in people of African, Asian, and Indian descent. And as the name suggests, if you take out the neuro part, it's characterized by recurrent episodes of optic neuritis and myelitis. And it's usually relapsing remitting. There's no, you know, MS has that progressive, that gradual worsening in level of function, but with NMO, it's typically not that, you know, it doesn't behave in that pattern. but the disability from each relapse can be much, much more significant. It can be debilitating. And the classical description of NMO, you know, before the era of treatment was that people without treatment, most tended to have blindness or wheelchair dependence within a few years. So this is something that is really, really can be debilitating. We now have so with NMO, unlike MS, it's an antibody mediated condition. So it's an antibody to the aquaporin 4 water channel. We'll talk about that in a moment. And so most people do make that antibody that we can test for in the blood. And so if somebody's positive for aquaporin 4 IgG, then they have to have at least one core clinical characteristic, and we'll go through that in a second. And if somebody doesn't have that antibody, then they have to meet at least 2 core clinical characteristics, and it gets a little bit more complicated. So for this, you know, for the scope of this talk, I won't go through that. But the core clinical characteristics, again, optic neuritis, acute myelitis, those are the most common. People can have what's called area post-rema syndrome, which is an episode of otherwise unexplained hiccups or nausea and vomiting. So sometimes these people actually, if it's not really understood, they may go to gastroenterology. And people have done that. I know of patients who've done that, who then, you know, had intractable vomiting for a while. They didn't know what the cause was. And eventually got the diagnosis of NMO. And so that's something that's very important to think about when we're thinking about these conditions. Brainstem syndromes, narcolepsy, not common, but it's out there. And then any other sort of, that number 6 is sort of a grab bag for any other syndromes. This is the area post-rema syndrome. You can see a lesion in the medulla. So as I mentioned, it's caused by an antibody to aquaporin 4 that's present on astrocytes. And this really explains the affinity to parts of the CNS that are aquaporin 4 rich. About 70% of people have those antibodies in the serum. So if we go through this, it's usually in the brain. We're talking about periependymal lesions, so they're periventricular. They sometimes can mimic the lesions that we see for MS, but you sort of have to put everything in context. And then in the dorsal pons, dorsal medulla, periaqueductal gray, so around, you know, really periependymal. In the spinal cord, we're talking about, again, longitudinally extensive myelitis. That's the term that we use. That spans more than 3 segments. So the treatment for NMO has also advanced. So treatment of relapses really comes down to high-dose corticosteroids and plasma exchange to get rid of circulating antibodies. And then as far as disease-modifying treatments, until 2009, there were no FDA-approved medications to treat relapses. So really, we had a few things. We had a few effective medications for sure, but just over the last year or so, there are now 2 very effective options that can prevent the majority of relapses in these people. One that in its study prevented essentially all relapses in patients that were given that medication. So just again to mention that there are some MS medications that may harm people with NMO, and so this distinction in diagnosis is very important. Just wanted to go over another case in neuroimmunology. I know we're close to running out of time, but so this is a 24-year-old previously healthy woman who developed hallucinations, personality changes, and then started developing generalized seizures. This is her brain MRI here. I think it may be a little subtle for you guys, but just before we go over the brain MRI, The cerebrospinal fluid shows, 50 white blood cells. Normal is less than 5, so it's what we call pleocytosis. It's a lymphocytic pleocytosis. Most are lymphocytes. Protein was mildly elevated, and EEG captured several seizures. And what we see on her MRI is hyper intensity of the limbic structures of the medial temporal lobes. So this refers to limbic. This is a case of limbic encephalitis, or we sort of use the term autoimmune encephalitis as a sort of a grab bag term to refer to antibody-mediated brain inflammatory processes that largely affect the limbic system as well as other systems, but limbic system affecting cognition, attention, memory. Now, since the presenting symptoms is psychosis and behavioral issues, memory issues, people may often be diagnosed with psychiatric conditions until the condition gets worse. So it's not uncommon for people to go that route. People having gone that route to eventually realize it's a neurological condition. The distinction becomes blurred at that point. And there are a lot of different autoantibodies that have been discovered that can cause this condition. Each of them have overlapping symptoms. They can cause cognitive dysfunction, limbic dysfunction, but they each have sort of somewhat different symptoms as well. This is just a list. It's outside of the scope of the talk, of course. There are new antibodies discovered every year. So this is something that there's been tremendous advancement in over the last, again, 10 years or so, 10, 15 years. Before 2007, we didn't know. So anti-NMDA receptor encephalitis is the sort of most well-known out there. We didn't know about that until 2007. So we're really, these are historic times when we're really that's sort of the most well-known, and then the others, the list has just ballooned over the last few years. And so a lot of times we see somebody who looks like they have autoimmune encephalitis, but then can be seronegative, meaning they don't make any antibody that we know how to test for. Sometimes these conditions can be associated with certain cancers, so we call that paraneoplastic, but sometimes they just occur on their own. So as far as the treatment as with similar conditions, so it involves immunosuppression with corticosteroids. You can use IVIG and also plasma exchange again to remove autoantibodies. If there is an associated malignancy, definitely people do better with treatment of the malignancy. So if there's a teratoma or lung cancer that is causing this paraneoplastic situation, removal of that tumor leads to improved outcomes. And if it's caught early, it can be really effectively treated with a really great outcome. And our department knows this very, very well. This is so on the left there is a picture of Suhail Najjar, who's our department head, department chair, who is an expert on the treatment of autoimmune encephalitis. And on the other side of the picture, there's Susanna Callahan, who when she was 24 and a writer for the New York Post, developed NMDA encephalitis and was diagnosed by Dr. Najjar and recovered beautifully. Wrote a book about it called Brain on Fire, and there's actually a movie about it on Netflix with Chloe there in the middle. So we know that people can, if diagnosed effectively, people can really be treated very, very well with a great outcome. And we know that prior to recognition of these of these entities, really some people probably ended up, sort of in the psychiatric wards due to this illness. So something that again we've made great advancements in recognition and diagnosis. So neuroimmunology. So it is the study of how the immune system interacts with the nervous system. As a neuroimmunologist, take care of a whole host of different conditions that can affect the nervous system, but these are just an example of several examples. And really, as you can see, that there have been dramatic advancements over the past decade in our understanding of these conditions, or the way we diagnose these conditions, and our ability to treat these conditions. And if you wanted, I'll include here, an educational resource if you want to reach out to anybody. Here, for MS, the National MS Society, the Consortium of MS Centers, those are the active groups. With NMO, it's Guthrie-Jackson, and the Autoimmune Encephalitis Alliance for Autoimmune Encephalitis. Of course, the NIH has a lot of resources as well. So thank you, and I'll open to questions.
All right, I'm going to open up the chat right now. If you want to stop screen sharing, you can then take a look there.
Okay. Stop sharing. Oh my gosh.
The questions come pretty fast, but just answer what you can get to.
I'm trying to think. Okay, it's 10:52, right? So let me see. Okay. So can you talk about the neuroimmunology of COVID-19? Yeah, so that's something that I'm actually involved with, in New York with a few different centers, trying to figure out. So I'm not sure what the question is. I don't know if the question is about what COVID actually causes, but with MS, we're trying to figure out how this affects people with MS and related conditions. And so far, it seems like people have been doing okay, despite being on certain immunosuppressants. As far as the neuroimmunology of COVID-19, there have been reports of acute demyelinating conditions, so what's called ADEM, which is acute demyelinating encephalomyelitis in people who have developed COVID, but it seems to be very, very rare. And it's also during a pandemic very, very difficult to study, because I know when the surge hit New York, we weren't really sending people down for MRIs with contrast. We weren't trying to do as much. We were trying to do of course what's clinically meaningful, but as far as sort of studying things, we were very limited. So we were doing very, very quick MRIs just sort of to minimize exposure. If we needed to do spinal taps, we did, but if it wouldn't really change management, we didn't necessarily. So only what was clinically meaningful, and so that limits our knowledge to some degree with regards to what COVID can do. But yes, there have been reports of ADEM with COVID. Since autoimmune encephalitis is often mistaken for schizophrenia, do you think all patients with first episode psychosis should be automatically screened? Yeah, I mean, I think that there should be a bare minimum. What that bare minimum is, it probably varies on the sites. I mean, I think first, people with what's called a first break, probably a routine EEG is not a bad idea, and NMDA antibody is an easy thing to check. So yeah, I mean, I think that makes sense. Now, there can be an argument made. Okay, should we give everybody with the first break a brain MRI? Again, it depends on resources, and that's a longer conversation. Interferon beta 1A is an older medication that is, I mean, certainly it was successful when we didn't have any other options, but it's not one of the more effective medications. And it does, when people always heard back in the day that MS medications had, severe side effects, the interferons were the culprits. And nowadays, people don't use interferons that often unless somebody's been on it for a very, very long time doing well and no issues, then they continue them. But very rarely do people start that as a first medication these days. So can MS further increase the risk of getting other progressive neurological conditions? No, not really. There are some associations between MS and PD, but there doesn't seem to be a correlation there. I think it's probably by sheer luck that people can have two conditions. Certainly, MS can worsen cognitive dysfunction, and so it can impact somebody. Okay, if they're developing Alzheimer's, and may decades later, it may make that worse, but no, not specifically causing other neurological conditions. What made me interested in this, especially, I think, as a neurologist, I like to, I think that the field has moved, dramatically, and there is continued activity in the field. It's not going to be the way we're practicing now is not the way we're going to practice in 10 years from now. I guarantee it. And I also like the idea of being able to help people and really change the course of I see these people who, young, 20-year-old runner who decades ago would this would have been a huge problem. Now can be really treated in a very effective way. I read an article that some scientists believe climate change could make MS symptoms worse for patients due to Utah's phenomenon. What do you think of this? I mean, I think, I think certainly, in a hot summer, we get more complaints of symptoms, but, I think it just means that people have to stay hydrated and cool down once in a while, for sure. That can exacerbate symptoms. Is there any sort of protective factor or benefit MS provides patients that have it, like for sickle cell disease? Not to our knowledge. So there's nothing that, sort of benefits people with MS to our knowledge, but that's a good question. Okay, so we have questions. So I have TM is transverse myelitis. IVIG, plasma exchange of steroids, here's some function back. Well, I think the next step is to absolutely see a neurologist and get some testing done, of course. MS affects motor function in ADLs, but does not decrease life expectancy. The data, the most up to date is that it does a little bit, but it doesn't, but obviously that data is based on older data, right? So if our first treatment came out 27 years ago, we don't have accurate data these days because our newer treatments are much more effective than what we had 27 years ago. And if we need to escalate, we can nowadays. So I would say it's minimal, if any effect. Why do you think women are more likely to be diagnosed with autoimmune conditions? I don't know. Yeah, there are lots and lots of theories, probably hormonal effects, but we really don't know. What's a typical cause of death for patients with MS? Typically, people with MS die of something else, but if there's severe MS, severe disability, that can be, infections are a common one. That's probably the most common. Can MS be a dormant gene that is triggered by blonde trauma? No. MS does not get triggered by trauma. No. Where do you think this field is going? So I think what we need to do, we need to make further advances in treating progressive MS, preventing people from having this gradual decline, because we're really good at preventing relapses, preventing new lesion formation, but this gradual decline, this probably neurodegenerative process, it eludes us. So I think we need treatment from that standpoint. Neuroregenerative treatment, so remyelinative strategies, that's a big place the field is going. So I think those two are really good. You read Brain on Fire, highly recommend. Good. And thank you. And And
it's
there are no drugs that are as of right now that have regenerative effects.
It's 11 o'clock now, so I think we're going to have to stop you here. But thank you so much for joining us today.
Okay, thank you for having me. All right. Thank you.